Module 7, Genitourinary and Reproductive System. Here's the required reading. We're going over Chapter 61 and Chapter 63. Major concepts are renal and urinary function along with urinary disorders. Okay, so we're starting with Chapter 61. This is the assessment of renal and urinary function. So here in this image, you have the overview of the anatomy and physiology of our renal system. That includes our kidneys that have ureters that connect to the bladder, that then connect to a urethra that then can drain the urine from the bladder that the kidneys made. So inside our two kidneys, we have over 1 million nephrons, and nephrons are the functional unit of the kidney. So each nephron has a glomerulus, Bowman's capsule, and a tubular system, which you can see here. And this becomes very, very important when we talk about how electrolytes are excreted from the body and how that all ties into our fluid balance. The kidneys have lots of different functions that are essential to maintain homeostasis in our body. So one is urine formation and the excretion of wastes. It also has regulatory functions related to fluid and electrolyte balance and acid-base balance. And then also they serve hormonal functions that we had talked about as renin production that helps to regulate blood pressure. They also secrete erythropoietin that stimulates the bone marrow to produce red blood cells. Also, they help to activate vitamin D, and also they produce and release bradykinin and prostaglandins. So the kidneys are very important organs, and we take them for granted many times. This is a depiction of urine formation. You can see on the image on the left-hand side, it starts with glomerular filtration, then tubular reabsorption, tubular secretion, and urine concentration. On the right-hand side, you see a picture of the glomerular filtration membrane. So as blood enters those capillaries of the glomerulus, the glomerular filtrate is formed. Okay, that's what's going to be filtered out. And this is by hydrostatic pressure. So it moves across the glomerular membrane into Bowman's capsule, and that filtrate contains water, electrolytes, and smaller particles like urea, nitrogen, creatinine, and glucose. So here we have tubular reabsorption and secretion. Again, this whole image here is a nephron, and you can see that electrolytes and other substances are regulated at different points in the tubules, and medications you will see will affect certain areas of these tubules. We have a renal threshold for glucose transport. So when patients are in a hyperglycemic state, we will see glucose spilled into their urine. So this image depicts that happening. Fluid intake and output. So this is a basic concept that we covered in foundations. So we intake our fluid either by mouth through liquids, fluids that we drink, or food that contain liquids like maybe fruit, something that has a high water content, or we can get it through IV, right? And then output, our stool has some fluid in it, the air that we exhale, we sweat through our skin, and then our urine, of course. So when we're assessing fluid balance, fluid intake and output is very important. So we need to be able to identify if a patient does not have enough output to maintain homeostasis. So here on the slide it says urinary output is normally equivalent to the amount of fluids ingested. Okay, so normally you drink a glass of water, then you're going to void about the same amount. And for a healthy person, an average of about 1,500 to 2,000 mLs in 24 hours. If you were measuring that, for example, like with a indwelling urinary catheter, that would be the equivalent about 40 to 80 mLs in 1 hour. So if you have a patient that has a urine output less than 30 mLs per hour, that means that their kidneys are severely impaired, and that is something that you need to report to the provider right away. This next slide is about antidiuretic hormone, or ADH. So it starts with our brain telling us that we are dehydrated. We don't have a lot of water in our vessels, and we are becoming hypernatremic because our sodium is becoming very concentrated from the lack of fluid. So that is going to elevate our blood osmolality, meaning that it's becoming concentrated. This is going to stimulate our brain to tell us to drink, to make us thirsty. It also is going to stimulate the posterior pituitary gland to release antidiuretic hormone, or ADH. And this hormone works by stimulating the distal convoluted tubule and collecting duct, which will in turn increase water absorption. So we're going to hang on to water when we have elevated levels of antidiuretic hormone. So this is going to fill our vessels, right? We're going to keep water in and solve the problem. Then we have aldosterone secretion. So this is another hormone. This hormone is secreted by our adrenal glands, and that you can see in this picture here, those two little blobs like little hats on the kidneys. So this is triggered by a change in blood pressure. So if a patient is experiencing hypotension, so low blood pressure, hyperkalemia, hyponatremia, all of these things can stimulate aldosterone secretion, which then triggers a whole domino effect. So this is going to stimulate the renal tubules to increase sodium reabsorption, which is going to keep more fluid in the body, which will then increase potassium secretion, because remember, potassium and sodium have a relationship. So if your sodium is increased, you're likely to have a decrease in potassium, and this will help fluid balance. This is one of the ways our body maintains homeostasis. Then we have our renin-angiotensin-aldosterone system, or our RAS system. Again, this is triggered by changes in our blood pressure. So if our body senses a decrease in blood flow volume or pressure, the kidneys will produce renin, the liver will produce angiotensinogen, and that will convert into angiotensin 1, which will then combine with the lungs, which are producing angiotensin converting enzyme, which is ACE, and altogether that will create angiotensin 2. Okay, so this will set off a chain of events which will ultimately increase our thirst. It will elevate the blood pressure because vasoconstriction will take place, and our kidneys will start to hang on to sodium and water. Okay, moving on to the structures of the body. So we have the bladder and the urethra. The left is a female, the right is a male. Again, notably, almost everything is the same except for the length of the urethra, larger on the male. Moving on to how we assess the urinary system. So we're going to get a good history and physical, just like any other condition. We're going to ask about their demographics and personal data. When the renal and urinary systems are evaluated, we want to make sure that we include that essential demographic data like gender, age, race, socioeconomic status, occupational history, dietary and personal habits. We should be questioning them about their overall health status, any type of fatigue, changes in weight, excessive thirst, any signs of fluid retention or symptoms that we might want to investigate further. Medication use, we have to get a thorough history of the current and past use of over-the-counter medications, any prescription medications, vitamins, herbal supplements, because many of these medications can affect the normal functioning of the urinary system. So if a patient is complaining about something, it might be just a side effect of a medication they're taking for something else. Then we have renal and urinary assessment. So when specifically assessing the renal and urinary systems, you want to question the patient regarding any changes in the appearance of their urine, like the clarity or the color or even odor, or a change in their pattern of urination. Maybe they're going more frequent at night, or maybe they have decreased the amount of times they urinate per day. And we also want to assess their ability to voluntarily control voiding. So do they have leakage? Are they having accidents? Stuff like that. Moving on to the physical examination, this should be a review from health assessment. So first we always inspect, and because these alterations in the renal and urinary systems affect all other body systems because they're all working together, you want to begin with the skin, just looking at the skin, the oral mucosa, the abdomen, and the extremities. So depending on what the patient tells you, what's going on, their subjective reports, then you may need to even inspect the urethra or the urethral meatus. Typically we don't get into depth on that type of area unless it warrants inspection because the patient is complaining of something like that. So when inspecting, you're going to want to look for poor skin turgor, rough texture, pallor, maybe yellow-gray color, flank bruising. All of those things can be indication of something going on with the urinary system. They may have an ammonia breath odor, stomatitis, which is inflammation in the mouth. The abdomen may be uneven. Maybe you may be able to see an abdominal mass. There might be edema in the extremities. And if you do assess that urethral meatus, it might be bloody, or there might be some discharge, purulent discharge, lesions, rashes, or maybe even some type of trauma there. And then we're going to move on to auscultation. So the patient should be supine, so that's with them on their back, and you want to auscultate over the abdominal aorta with the bell of the stethoscope. And when you are doing this, you're listening for a bruit. It sounds kind of like a whooshing sound, and that's produced by an increase in the volume of blood traveling through a vessel. So anytime you're listening to a vessel, and it needs to be a pretty big vessel, and you hear a whooshing sound, that is a bruit. So the presence of a bruit means that there is altered blood flow to the kidneys and warrants further investigation. Okay, then moving on to palpation. So again, the patient's in the supine position. You're going to lightly palpate in all of the 4 abdominal quadrants. And you want to ask the patient if they're feeling any type of discomfort while you're doing that. You may feel the bladder. If the bladder is full, you will most likely feel some distension. But if the bladder is not full, then typically you can't feel the bladder. And then you also want to palpate the kidneys. That's when you have this bottom picture here. You have the patient sit up. You put your hand over where the kidneys would be, right to either side of the spine, and then you hit it with a fist, not too hard, and then you ask the patient if they have any discomfort. Percussion. Again, the patient is supine. You're going to percuss over the symphysis pubis upward toward the umbilicus. So as RNs, we don't typically do this. We leave this up to the advanced practitioners, but it is something that you should know just, for your own knowledge. So when you percuss, dullness is the sound that you'll hear over a distended bladder. And a bladder containing no urine, or maybe just a little bit of urine, will produce no sound when you percuss it. You want to assess for flank tenderness and pretty much any tenderness in the area. Diagnostic studies. So blood tests are relatively cheap. So if a patient complains about, urinary issues or flank pain or anything, they are going to get blood tests. And the way we assess for renal function is going to include serum creatinine, BUN, and BUN creatinine ratio. So those are going to be the most common. Additionally, the patient could have a uric acid level, bicarbonate level, so electrolytes, including sodium, potassium, phosphorus, calcium. That could also be a reflection of kidney function. So we want to look at the big picture. And urine tests. So we can do a lot of different urine studies, and the most common ones are going to be bedside urine dipsticks, UA or urinalysis, culture and sensitivity or CNS, creatinine clearance, and urine cytology. Actually, at the bedside, I have never used a urine dipstick. I think those are more commonly used in the emergency room, primary care, or clinic settings. Diagnostic studies, lots of different studies. We can do an ultrasound. Oftentimes, we have a bladder scanner that's kept on the unit. You don't have to get an order for that. That is a nursing intervention that you can do to check to see if there's urine in the bladder. There's also a regular ultrasound that the patient goes to radiology for. The nurses don't do that one. There is x-rays of the kidneys. We call that a KUB, kidneys, ureters, and bladder. It is also used for abdomen views. So you'll hear that when we talk about the GI system, a patient having a KUB. Patient is lying in the supine position, so on their back, and that x-ray can give you the size and anatomy of the renal system structures. It can detect masses, obstructions, calculi, and it's pretty quick and inexpensive, so patients will commonly have those x-rays. We have intravenous urography, so intravenous means that the patient's going to get an IV dye. Usually it is an iodine dye, so you want to make sure the patient doesn't have allergies to shellfish or iodine. CT, MRI, cystography, urethrophy, and arteriography. Also, renography, renal biopsy, and cystography. So the left picture here is a renal biopsy. The patient's done in the prone position with ultrasound guidance. And then the picture on the right is a cystoscopy. So this is a surgical procedure usually used to treat bladder problems. And you can see in that picture there's a cystoscope. It is a device that has a light at the end, and it's inserted through the urethra while the patient is sedated. Yes, sedated. And if you look in this picture, that is called a lithotomy position, where they're on their back with their knees bent. So this cystoscopy can be used to look for bladder trauma, urethral trauma, or any type of obstructions that are in the urinary tract. If their patient has an enlarged prostate, a cystoscopy can also be used to remove pieces of that prostate or the whole prostate. So it's the same type of device. So next we're going to talk about urinary disorders. This is chapter 63. First off are urinary tract infections. I think all of you are pretty familiar with this one. So pathophys, bacteria or something else goes into the urethra. And remember, our bladder is sterile, so we shouldn't have anything going in there. That bacteria is going to cause inflammation and potentially infection. So some risk factors for UTIs include sexual activity, diabetes, poor hygiene, estrogen deficiency, recent catheterizations, foreign objects, benign prostatic hyperplasia or BPH, and a cystocele, which is a bladder prolapse. So another note, say it again, that females are at risk for developing UTI because they're because of their short urethra, and its close proximity to the vagina and the rectum, which harbors a lot of bacteria. Clinical manifestations of UTIs. So patients will complain of bladder irritability or dysuria. Dysuria is painful urination. Also may feel burning when urinating. Urinary frequency, so they have to void very frequently. Urgency, when they have to go, or they may have an accident. Urinating small volumes, so the patient feels like they have to go to the bathroom, but when they go, only a little bit comes out. Gross hematuria, that's when you can actually see blood in the urine. Microhematuria is when you can't see blood in the urine with your eyes, but when put under the microscope, there are evidence of red blood cells there. And then suprapubic pain is another clinical manifestation of a UTI. And if there are systemic symptoms like fever, nausea, vomiting, and flank pain, then the infection has probably migrated to the kidneys. Okay, so that means it started in the urethra, goes up to the bladder, and eventually, if left untreated, it can migrate all the way up to the kidneys. Once it infects the kidneys, we call that pyelonephritis. So how do we diagnose a UTI? So typically, when a provider listens to the signs and symptoms, clinical manifestations, patient's health history, they can usually determine that it's a UTI. Along with looking at the urine, which may look like this picture in the left-hand corner, cloudy, dark, foul smelling, and that one in the picture is kind of light and milky, but dark, it could be a brown or a dark concentrated yellow. So a urine specimen that looks like this one pictured here would most likely indicate that there's lots of bacteria in there, there's lots of white blood cells and nitrates. So that would be a sign that the patient does have an infection. And of course we can culture it, so culture and sensitivity, but that doesn't come back right away. That takes a couple days to grow. So it's really important that you do your assessment and that you ask the patient the right questions. So treatment-wise, UTI is an infection, and if it's caused by a bacteria, then antibiotics are appropriate. So medication is the first line of treatment, and that's going to be antibiotics. So the choice of antibiotic is going to depend on the urine culture. So typically the patient will get started on some type of antibiotic, and then once the culture comes back, they may change it to whatever specific antibiotic will is best for that specific organism. Some common medications that you may see in practice are Bactrim and ciprofloxacin. Those are very commonly used to treat UTIs. And then also Pyridium here in this picture is used for pain, and it's used to treat actually the pain that accompanies UTI. So like that burning pain, increased urination, increased urge to urinate, this Pyridium can actually help with that. Then we have surgical management. So typically people with UTIs don't have to have surgery unless there's something else going on. For example, if there's kidney stones and they're obstructing urine flow and that's what caused the UTI, then likely they're going to need surgery to remove that. Or maybe the patient has incomplete bladder emptying. So when you don't void completely and you leave urine in the bladder, it stays stagnant there, and that can harbor bacteria. So if there's a pelvic organ prolapse or enlarged prostate, then that may warrant the patient to need surgery. So some complications that can happen: drug resistance. Of course, whenever we're dealing with prescribing antibiotics, there is a risk of drug resistance. Also pyelonephritis and renal abscess. So a lot of times an untreated UTI can have that bacteria, like I mentioned before, just crawl up the ureters into the kidneys, and the patient will develop pyelonephritis and can even develop renal abscesses, which are those pockets in the kidneys of just purulent fluid. Next, we have urolithiasis. So these are renal stones, kidney stones. These develop from microscopic crystals in the urinary tract. They kind of clump together and then they make a calculus, which is a stone. So they can occur in the kidneys, in the ureter, and the bladder, but actual renal stones are the most prevalent. If a patient has calculus in the kidney, we call that nephrolithiasis. And if there is a calculus in the ureter, we call that uterolithiasis. So kidney stones are pretty common. There's 12 out of every 10,000 people in the US will develop a kidney stone. It's more common in males and more common in Caucasians than in African American. Risk factors for urolithiasis. If it runs in your family, then you are at higher risk for having a kidney stone. Also, dietary habits, like if you have an increased sodium intake. Industrialized countries have a higher incidence of stones, and this is due to a high dietary protein intake. The problem with the kidney stone is that it may cause obstruction. So if you have kidney stones, but they're small and they just kind of bounce around through the ureter or in the kidney, they may not be doing any damage. They may not even cause any symptoms, but as soon as that stone squeezes into an area that's too tight and it starts to block urine flow, blood flow, then that's when we have a problem, and that's when the patient will experience a lot of pain. So clinical manifestations, number one is going to be severe pain wherever that stone ends up stuck. So wherever it lodges itself in the ureter, most likely you're going to have a lot of pain there. Pain associated with urinary stones is usually colicky with sometimes nausea and vomiting. And really, wherever that stone is located will determine how severe your pain is. You may have referred pain to the flank, or even abdominal genital pain, just depending on where that stone is. Gross hematuria and microhematuria can be present with any stone, doesn't matter where it's located. And that will usually happen in 95% of patients. So as part of our general health promotion, patients should report when they see blood in their urine at any time, because that can be a kidney stone, it can be lots of things. So that's something they should definitely report. Diagnosing a kidney stone, usually patients will have a CT scan, non-contrast. It is quick and they can see it right away. A CT scan can also pick up any type of obstruction in the urinary system, like hydronephrosis. This is when the kidneys they have edema, and that happens when urine flow is blocked and that urine backs up and it accumulates in the kidney. So they can also do a KUB x-ray, that's called a kidney ureter bladder x-ray. And this is also inexpensive and fast. It doesn't have the details as a CT scan does, but it can detect some type of stones. So the treatment for kidney stones really depends on the type of kidney stone and how large it is and what type of damage it's causing. So 50% of stones that measure less than 5 millimeters will pass spontaneously. So for those patients that have those the smaller stones and maybe not that much pain, and maybe they did not develop hydronephrosis or some type of obstruction leading to infection, then most likely we're going to try to see if they can pass it on their own. That will be the first option. So patient may be prescribed narcotics or NSAIDs with antiemetics during this trial period to see if they can pass it. Some medications that can be given are Flomax and Cardura and Terazosin. These help to relax the musculature of the lower ureter and to help that stone passes. But if that stone doesn't pass after 4 to 6 weeks, and the patient may start to develop other type of, it may get worse. It may start causing the obstruction, that backflow urine. So that's when the patient will need some type of surgical intervention, something more invasive. If a stone is larger than 10 millimeters, or it's causing severe obstruction and pain that's unrelieved by all of those measures we just talked about, then surgery will most likely be planned, and it may even be done on an emergency basis, just depending on what's going on with the patient. They can have a ureteroscopy, which is pictured here in the center, percutaneous nephrolithotomy, and extracorporeal shockwave lithotripsy. These are all done, again, just depends on the size and location. So complications, pyelonephritis, that is the actual kidneys are infected, urosepsis, so that bacteria travels to the blood, and irreversible renal damage. So those are the things that we want to avoid. So interventions, remember pain is associated with this, so pain is going to be one of our priorities. Maintain fluid status because our kidneys are compromised, so we want to make sure that they are excreting enough urine and the patient is drinking enough fluids, or maybe they need it through the IV. We want to strain the urine. Here's a picture of a strainer here, and these patients can take this home with them. And there are different types of stones, so it really just depends on it could be based on diet, it could be based on medications they're taking, but they may look different. So we definitely want to collect those for examination. And then the patient may need an indwelling urinary catheter if the patient is unable to void on their own. And that's because we definitely don't want stagnant urine in the bladder, because then that can lead to, again, risk for infection, bacteria. And then teaching, so definitely tell them how and why we want to strain the urine. They should report any type of worsening symptoms, especially like systemic infection signs and symptoms, so like fever, chills, nausea, vomiting, uncontrolled pain. And then we want to tell them about how to prevent stones in the future, because once they have one stone, they're at greater risk for developing another stone. So hydration, that is an important one. Low sodium diet, increased dietary intake of citrate, decreased dietary intake of oxalate. And yeah, that's about it. You can see on this x-ray, this is a KUB, you can see a little stone here. All right, moving on to incontinence. So I know we covered this in foundation, so this should be a review. So there are many people that have urinary incontinence, over 20 million in this country, and that's partly because of our aging population. Those baby boomers are in their 70s now, 60s, 70s, even approaching their 80s. So we have a lot of people with incontinence, so this is a very important concept to understand. So pathophys, involuntary or uncontrolled loss of urine in any amount. So even if you are your age now and every time you sneeze, a little bit of urine comes out, you are considered to have a type of incontinence. So it doesn't matter how much leaks out, that is a degree of incontinence. Clinical manifestations, so bladder irritability, dysuria, which is painful urination, urinary frequency, that's when you have to urinate quite often, urgency, you have to go now, urinating in small volumes, so you feel like your bladder's full, but then when you go to void, only a little bit comes out, gross hematuria, so that's blood that you can see with your eyes, microhematuria, that's blood that is seen under a microscope, and also suprapubic pain. So this is when you need to ask questions. So when we're diagnosing this, if a patient comes in and you hear some of these signs and symptoms, these actually sound very similar to a UTI. So we want to make sure we're asking the appropriate questions. And we want to know about any medical history, of course, any urological history, if they've had any surgeries in that area or other already diagnosed conditions. We want to know their voiding routine. How many times do they go every day? What does it feel like? Anything abnormal that they've noticed. Their neurological status. Do they have any spinal cord injuries or other injuries having to do with their nerves? Because the messages have to be sent to the brain for the brain to tell us that we have to empty the bladder. So the nervous system, the central nervous system, is very important also. And then reproductive history, especially in females. So after having a vaginal birth or even a cesarean section, there are some structures that can be affected. So that might be the reason for the incontinence. And then we also want to do an examination and ask the patient to create a voiding diary, which is very useful because we often don't remember, all of the details of how many times we voided or, every single description of each. So having them kind of document that for a few days is very helpful. This table is from your textbook, Types of Incontinence. I'm just going to go through a couple of these really quick. So the first one at the top is stress incontinence. This is very common and it's more common in women, and that is due to childbirth. That's what makes it more common in women. Just the baby coming through the vaginal canal and all of those structures that it affects can cause urine leakage. And postmenopausal women, smoking, and obesity can also cause stress incontinence. So that could also affect males. And what the patient will describe will be when urine leaks, when there's abdominal pressure increase. So laughing, coughing, lifting exercises. Then we have urge incontinence, and this is when you have to really go right now, or you feel like you're going to have an accident, and you will have an accident. So this is when there are irritants, bladder irritants like caffeine, artificial sweeteners, or nicotine that can cause urge incontinence over time. You can have a mix of the different incontinences. And then we have overflow, functional, and reflex, so you can read those on your own. All right, so what do we do for incontinence? So if we can, we want to prevent or stop the urinary leakage. We want to make sure that we are taking care of the skin, because we know that urine can cause skin breakdown when it's left sitting on the skin. If we can strengthen the pelvic floor, we want to do that. So that's going to include exercises. There is called a pessary device, which is pictured here. It fits into the vagina and it kind of supports the bladder in order to control incontinence. So again, this depends on what is causing the incontinence. So that's what we try to focus on. Surgical management, again, if the patient will benefit from, for example, a suburethral sling, artificial urinary sphincter, again, that just really depends on what is the cause. Medications. Again, not every patient is going to be prescribed the same type of drug. It really just depends what the problem is. So we have anticholinergics and antispasmodics. So those are going to block impulses from the parasympathetic and the PNS, parasympathetic nervous system, to relax and control the bladder. Tricyclic antidepressants, those decrease the bladder contractility, and they also have an antispasmodic effect on the bladder. Then we have alpha adrenergic blocking agents. These will promote urethral relaxation, and it will help urinary retention because the urethra relaxes and it allows the urine to pass. Topical estrogen, this is mostly for women like in menopause, and then everything becomes very dry, and if this is causing incontinence, we can give topical estrogen that helps to restore tone in the urethra and vaginal areas. Then we have beta-3 adrenergics, so those will help to relax bladder muscles. So these can be used in combination with each other or just one at a time. It just depends on the patient. When it comes to teaching, so for medications, we want to make sure patient knows why they're taking them and possible side effects. Technique for clean intermittent catheterization. So the patient may require self-catheterization. If their bladder is not able to empty out on their own, then they may need to be taught to do that themselves. So we just want to make sure that they have their supplies and they have adequate teaching to make sure that they can actually do this at home. And then we talked about avoiding diarrhea. Okay, so we just talked about these medications. You can kind of read through them. Next is bladder cancer. So we already know what cancer is, we know how it develops, we know how it spreads, so we're not going to go into that. But let's talk about bladder cancer. So bladder cancer is the 4th most common cancer in men and the 8th most common cancer in women. So that's pretty significant. And pathophys-wise, this is going to be from genetic changes in target cells, which is like all cancer. So the cells of the bladder become mutated for some reason and they start duplicating, and then all of a sudden you have a little cancerous tumor. Risk factor: smoking, aromatic amine exposure. So amine is something that is released after certain, it's a byproduct of certain materials, so like rubber and chemical things that are usually very industrialized. However, that's also released through hair dye. So for whoever uses hair dye, that's why you should be in a well-ventilated area, because you can potentially increase your risk for bladder cancer. Chronic infection and inflammation from chronic catheter use, and incomplete bladder emptying. Okay, we're going to move on. Signs and symptoms of bladder cancer. So painless hematuria is the most common presenting symptom of bladder cancer. So again, if a patient sees blood in their urine, they should report it. It can mean many different things. So it could also mean bladder cancer. And as we just talked about, it could also mean a kidney stone. So very important that patients come and report things like this early so they have a better chance of having a positive outcome with treatment. Diagnosing this, so we want to make sure we get a good history and physical. We want to know about risk factors, like do they smoke, or maybe they're exposed to secondhand smoke, that sort of thing. Cystoscopy and biopsy, blood and urine tests for tumor markers. And remember that biopsy is the definitive way to diagnose any type of cancer. Treatment, we have intravesical therapy, topical chemotherapy, and precision medicine. So intravesical, we're talking about inside the bladder. So an example of that would be brachytherapy, where we put those little radioactive seeds inside the bladder and they work in a localized area versus a systemic area. They can also put in a fluid chemotherapy fluid where it sits in the bladder for a certain amount of time and then they drain it. So we have some options, and if it is very severe, then they'll remove the entire bladder, which is a radical cystectomy. So interventions, we want to make sure we're giving and educating ordered medications to the patient. They may need continuous bladder irrigation, especially if they had a procedure. And when we talk about the male reproductive, I'll give you more details on continuous bladder irrigation. And we want to maintain accurate intake and output, which usually involves having an indwelling urinary catheter. Complications, bleeding, pain, chemotherapy side effects, and teaching-wise, just want to make sure the patient's aware of all the treatment and the possible outcome. And with any type of cancer, even after treatment, when maybe they say you're free of cancer, they should always follow up for the rest of their life because cancer can come back. And that concludes this chapter.